All right, everybody. You guys can keep getting your food. I'm going to get it started. Happy New Year, everybody. I'm Jürgen Unitzer. I chair the Department of Psychiatry and Behavioral Sciences, and I'm going to welcome you to our first Grand Rounds presentation this year. This is a presentation we do in honor of Dr. Herbert Ripley. Dr. Ripley was the first chair of the Department of Psychiatry from 1949 to 1969, and we do one presentation every year to honor him. Today it gives me great pleasure to welcome our speaker, Dr. Rinat Beydas. Dr. Beydas is on the faculty in the Department of Psychiatry at Penn. She's a leading expert in evidence-based practices, in particular CBT, and she's a real expert in a still relatively new science called dissemination and implementation science. And she asked me today on the way over here, what kind of people show up at this meeting? And I said, there are going to be 5 or 10 people who could give a portion of this talk. There's going to be 20 people who know enough about dissemination and implementation science that they'll know what you're talking about. And there's going to be a whole bunch of us who don't know that much about it. And so you've got to do it all. And I think she will do that. Rinat is already a great colleague and collaborator for a whole bunch of people in this room. We would very much like to work with her even more closely. She and her family are visiting from Penn. We weren't actually sure if we were going to have this today because I think it was like minus 200 degrees in Philadelphia yesterday. But Alaska Airlines got her out, so we're very happy to have her here. And I'd like to ask you to give her a really warm welcome here.
I should have worn my heels today. I'll do my best to peer over the computer. Thank you so much. It is an honor to be here. As Jürgen mentioned, we had something called a bombogenesis on the East Coast, a snow cyclone, and yet I'm standing here thanks to Alaska Airlines, so I know who I'm going to fly next time I have a choice. So it's really my pleasure to be here today and to see so many friends and colleagues in the audience. So I want to first start by orienting you all to what I hope to accomplish in the time that we have today. And I just want to say that if you have questions for clarification at any point, feel free to raise your hands and ask, since I would prefer to answer it at the beginning than to have it linger, unless it's a discussion question. So I'll start by telling you a little bit about how I came to be standing here calling myself an implementation scientist. And I will give a little bit of a background on what implementation science is, just to make sure that we're all on the same page. I'll then really talk about the evolution of the field of implementation science. Even though it's a young field, there has been an evolution over the past 1 to 2 decades. And I'll try to do so within the context of my own research. And then I'll conclude by talking a little bit about future directions for myself and also for the field as I see it. So I want to start first by sharing an observation with you all. And the reason that I do this is because I, a decade ago, never thought that I would be standing up here calling myself an implementation scientist. I'm trained as a clinical psychologist, and I did my training at Temple University with Phil Kendall, who's a leading treatment developer for cognitive behavioral therapy for child anxiety. I thought I was going to be a treatment efficacy researcher. That's the path that I was on. But I made an observation when I was a graduate student that has led me on this path. So when I was a graduate student, I did a lot of CBT for child anxiety. And you can see here a picture of the body drawings that we do with anxious kids to help them identify the somatic feelings in their body and exposure. I don't like rats, so I like to put this up as my own personal exposure. So Phil Kendall had really inculcated a deep sense of culture of CBT in this clinic. And what happened is best illustrated by this young lady, Jennifer. So Jennifer came to see me. She was a 16-year-old, and she had received a number of different services in the community and had not gotten better. And at the point when she came to see me, she was no longer attending school, and she was incredibly anxious. She was having panic attacks. And over the course of about 20 sessions of CBT, she started to do better. And this drawing illustrates all the things that she was able to do after CBT. So go back to school, she applied to college, she was able to do sleepovers. And I really became convinced that there was a real problem, that kids in the community didn't have access to CBT. And at that time, I was really focused on anxious kids. And that really sparked this interest in the research to practice gap for me. So at the same time that I was kind of puzzling around why kids weren't getting access to cognitive behavioral therapy in the community, a new science was developing. And so what I was experiencing was not idiosyncratic to the particular setting I was in. And so we know that, at least in the case of child psychiatric research, but in many other areas, treatment developers have been quite prolific over the past 50 years. There have been a few reviews done. This is one that, that identified that there are over 750 treatment protocols, almost 500 studies, and 86 different evidence-based approaches for the most common childhood disorders. So our problem is not in generation of discovery. We know that it takes 17 years for 14% of research to make its way into practice. And that's really, if you think about it, if you had a child right now who had a condition for which a practice was not yet available, that means in their lifetime as a child, they probably would not have access to that evidence-based practice. We also know from the empirical literature that usual care, particularly for youth psychiatric disorders, has great breadth but not depth. And so Anne Garland and colleagues have done seminal work in that space. And so we know that usual care does not look as much like evidence-based practice as we would like. And we know that there's something called the implementation cliff, which is that the effect sizes that we see in our efficacy trials drop pretty dramatically when the same treatments are taken to community settings. I think that this quote, although it does not explicitly call for implementation science, really speaks to me as an implicit call. So this is Tom Insel, the former NIMH director, and he said in a recent interview, "I spent 13 years at NIMH really pushing on the neuroscience and genetics of mental disorders. I think I succeeded at getting lots of really cool papers published by cool scientists, maybe some of you in the room, at fairly large costs. I don't think we move the needle, though, in reducing suicide, et cetera." And so I think implementation science is about moving that needle. And so I think he's really making a call for that. So I present this definition. I know there are a lot of experts in the room on implementation science, but I think it's helpful to all share the same terminology. This is from the inaugural issue of the journal Implementation Science, the scientific study of methods to promote the uptake of research findings in real-world practice settings. And I want to highlight here that the main goal of implementation science is to improve population health by improving the quality of care. So that's a really important point that I just want to highlight. So there are many questions that fall within the purview of implementation science. Here are just a few to help orient you. So is it possible? Can clinicians implement evidence-based practices in their settings? What kinds of supports do clinicians need to implement evidence-based practices successfully? Are there factors about the context that are associated with implementation? So those are the types of questions we tend to be interested in. So I mentioned in the introduction that I think that the field has evolved pretty substantially over the course of a short period of time. I think the whole thing started, and I call this wave one of implementation science, when leading experts and treatment developers started decrying the lack of empirically supported treatments or evidence-based practices in community settings. And there were guidelines and task forces. This is like the Chambliss and Holland and Ollendick work. So people in academic medical centers were saying, why aren't people in the community doing evidence-based practices? Wave two was really focused on training. So once it became clear that people weren't doing evidence-based practices, everyone said, well, let's just train everyone. And if we train them, then people will do evidence-based practices. And that fell a little bit flat. Training by itself doesn't seem to be a way to change people's behavior. And so that created this wave three, which was really focused on understanding context deeply and contextual factors associated with implementation, and has resulted in a lot of heuristic frameworks which have been developed. And wave 4 is where I think we are now, which is really thinking about targeting our implementation strategies in a more thoughtful way with an eye towards mechanism and building causal theory in the space of implementation science. So my hope is that I'm going to show you the journey through parts of this, because I wasn't around for all of these waves through my talk today. Did you get the picture, Aaron? Good. So I'm going to give us a framework to kind of guide some of the studies that I'll be presenting today. And as many of you may know, there's over 61 frameworks in implementation science, so I could have chosen one of many. But this one I think is particularly helpful. It's by Enola Proctor and colleagues. And one of the reasons I really like it is that it differentiates between the actual interventions themselves, or the evidence-based practices, and the strategies that we use to implement those interventions. So those strategies are ecological or multi-level in nature. And so, for example, a system-level implementation strategy might be an enhanced rate for the provision of an evidence-based practice. An organizational level implementation strategy might be changing the organizational culture or leadership in a particular organization. Provider level implementation strategies is where we spend most of our time and is around training. And then consumer level implementation strategies is relatively understudied, but is about creating demand for evidence-based practice. So this distinction in itself, before this framework, was not fully fleshed out, that the practices are separate of the strategies. The other thing that I think that Enola did that was really important was differentiate between implementation outcomes, which are more intermediate, from service and client outcomes, which tend to be the bread and butter of efficacy and effectiveness studies. So the implementation outcomes include things like fidelity, or how closely a provider follows a protocol, or penetration, how many providers in an organization actually use the evidence-based practice. So I'll come back to this framework, but I think it helps kind of give us a shared language moving forward. And I'll note that this is one of the heuristic frameworks. So this does not achieve the goal of moving towards causal theory, but it helps us kind of understand the types of questions and outcomes within the fields. So I'm going to spend some time now sharing with you some of my work over the past 5 years, where I've been really in the wave 3 of focusing on understanding the context that I'm trying to implement evidence-based practices within. But before I do that, I just want to share something with you really quick, which is a quick jaunt into wave 2, which represents all of my graduate training and my graduate research. So you guys are all reading this, but basically, I made the assumption that the reason when I saw my client Jennifer and I started thinking about why people weren't using CBT in the community, I thought it was because they didn't know how. And so I did a series of studies really focused on training. And what I could have done was read Dilbert and looked in the cognitive psychology books. But you can see here that there really is this understanding that training is important. And I'm not saying that training isn't important, but that it's not enough. And I'll just add one additional anecdote in this kind of wave 2 area of research, was that I was talking to a community clinician after a training study that I did in a consultation call. And she shared that she was hoping to do an exposure with a youth with contamination concerns. And I said, well, okay, like, let's go to Starbucks, touch a toilet, and then eat a donut, which I've done for exposures. And she said, what? You can leave the office when you're working with kids? She was like, I can't do that. And so I got creative. So we brought in she brought in the top of the toilet seat, and that achieved the goal there. But the point I'm trying to make here is that context is important. And so the organizations that therapists work within really constrain or facilitate ability to use evidence-based practice. So now I'm going back to context. We're back in wave 3, and I'm going to tell you a little bit about my work in the city of Philadelphia. So Philly is a big city, and there's over 1.5 million inhabitants. It has some really great things about it. You can see in the corner here, we have a prolific mural arts program. There's also, it's the highest level of poverty, a lot of crime, and we have a really large behavioral health system. And so it's a 1.5 billion a year funding stream, and it oversees all of the Medicaid services in the city. And this is Dr. Arthur Evans. He's our former commissioner. He's now the CEO at the American Psychological Association. But when he came in, about 11 years ago, when he came to Philly, he was overseeing this large system that was serving 100,000 consumers annually, 30,000 of which are children and families. And he decided he wanted to transform the system into one of recovery. And part of that was about getting access to evidence-based practices as a matter of social justice. And so he ended up partnering with a number of leading treatment developers over the course of 10 years. And the city started implementing different evidence-based practices. So the oldest partnership is the Commmunity initiative, and is an effort to implement cognitive therapy across the city. That was followed by a trauma initiative, which included prolonged exposure, trauma-focused CBT, then dialectical behavior therapy, and then parent-child interaction therapy most recently. But you can see that the city is implementing multiple evidence-based practices within its context. So what Dr. Evans and others realized is that each of those initiatives that I just mentioned briefly were really siloed from one another, and that they were not learning from each other, and that they faced similar stuck points. And so he put together something called EPIC, the Evidence-Based Practice and Innovation Center, which is led by Dr. Ronnie Rubin, which is really intended to oversee and kind of administer the evidence-based practice activities within our system. Public academic collaboration, so it includes investigators from Penn and from the city. And I could spend the whole time talking to you about the different things EPIC has done. I won't, but if you'd like to read a paper about it, it's listed here. And you can see in this map, this is the county, all those yellow dots represent providers that are implementing evidence-based practices. So you can see that there's nice penetration. So this was all kind of rumbling right when I got to Penn. And so I ended up putting in for a K-23 Career Development Award to study what happened in a system when something like EPIC, a centralized infrastructure, was created. And this was a prospective longitudinal observational design, so I was not manipulating anything. I was just kind of watching to see what would happen. And just to go back to that model that I presented briefly on earlier, you can see there's 5 different intervention strategies going on within the system. And that might seem like a lot. In LA County, there's like 61. And then there's implementation strategies going on that I'm not manipulating, that are just kind of happening. So the system has an enhanced rate. The organizations, there's been a lot of work around leadership buy-in and a lot of training and ongoing consultation. And in this particular study, I'll be talking about use of cognitive behavioral therapy, which I'll call Fidelity here, but some people might cringe because it's self-reported, but just bear with me. I'll talk a little bit more about that in a moment. So this observational study was 5 years. We collected data in 2013, 2015, and 2017. 2013 is conceptualized as pre-EPIC, and the latter time points are after the initiation of EPIC. And what we did is that we asked the Community Behavioral Health to give us a list of all the providers that saw kids in the city, and there were 29 of those providers served 80% of the kids in our system. So we reached out to them through purposive sampling. We tried to get them on board. We got 19 agencies, 23 sites, and 130 therapists in that first wave. And in later waves, we were able to not only keep the people we had, but add more people. We had higher numbers for therapists as well. And so the total sample is quite nice. We have a really rich data set of therapist behavior. So we've published a lot from this data set already. I'm just going to be talking to you about 2 main things that I think is particularly interesting. First, what drives provider behavior in a large system that's implementing evidence-based practice, and then talk to you a little bit about some qualitative work that we've done. I will say, though, we did analyze the longitudinal data, and I am going to give you a teaser for it. So this will be the first time we kind of share those results. So I'm excited about that, but don't hold me to it. So in this first study, this is really using data from 2013 that was published in JAMA Pediatrics. We were really interested in this question of, is it who you are as a therapist that dictates what you do with a child in a therapy session or where you work? So up until that point, folks who studied therapist kind of level factors were separate from the folks who were studying organizational factors. And as part of this work, I really wanted to marry those 2 approaches. And so I'm just going to give you some details about how we measure the various things that we were interested in, and then tell you some results. So we were interested in understanding therapists' backgrounds. So we did that using a background questionnaire, their attitudes. We used Greg Aaron's evidence-based practice attitude scale, and also their knowledge about evidence-based practices. So broadly, the constructs that we had at the therapist level was demographics, attitudes, and knowledge. We were also very interested in using gold standard measures for the organizational constructs. And I want to be clear here that when I say organizational construct, I mean a construct that's aggregated up to the organizational level. So we had in this first wave 23 sites that we were working with here. So we used Charles Glisson's organizational social context measurement scale, which is the gold standard for gleaning organizational culture and climate. Organizational culture refers to the sense or expectations or norms of how things are done in a particular organization. I like to give the example that I once gave a talk in Eugene and everyone had their dog in their lap. The culture there is that that's something that happens that doesn't happen in Philly as much. And then there's also organizational climate, which is the impact of the organization on an employee's well-being. So we measured those two constructs. We also measured implementation climate, which has been hypothesized to be more proximal to implementation than this more general organizational constructs. And implementation climate refers to the sense that implementation of evidence-based practices is expected, supported, and rewarded. And we used Greg Aaron's scale, and we also used Greg Aaron's scale of implementation leadership, which is the sense of whether or not the leaders in the organizations were perseverant and supportive around implementation of evidence-based practice. Oops, I have little leaves there. Finally, to get at use of evidence-based practice, we use something called the Therapist Procedures Checklist. That's Robin Weersing's measure. This allowed us to glean use of various strategies. It's a 62-item self-report measure. I'm going to tell you just a little bit more about it here. So it breaks down broadly into 3 subscales. One is cognitive behavioral strategies, one is family strategies, and one is psychodynamic strategies. We asked the therapist to report on a representative client on their caseload that they had seen for some time to tell us what types of strategies they had used. And what you can see here, the range is 1 to 5, is that they reported using kind of everything a little bit, which is very consistent with the usual care literature. And we're actually looking at the data in new ways now. I have a postdoc who's using latent profile analysis across all 3 waves to see if we can see profiles rather than look at it in this way, which is kind of, it's a little bit less nuanced. So let me orient you to this graph. So you can see here the set of predictors. So the blue predictors are the organizational level factors that I described, like organizational culture and climate, implementation leadership. And the red factors are the clinician factors, so knowledge and attitudes, demographics. And on the x-axis, you can see those different therapy strategies that I noted. And then on the y-axis, you can see the percent of variance accounted for by that set of predictors. And you can see that there's an interesting pattern here. So the strategies that we consider to be evidence-based for kids, CBT-based strategies, family-based strategies, the organizational factors predicted more of the variance than the therapist level factors, and we saw the opposite pattern for what we consider to be less evidence-based for the treatment of use. And so you might ask, well, what does that mean? I think the implications are that it matters who you are and where you work. So we really want to be thinking about both therapist and organizational factors when we think about implementation, which is not rocket science. It does help us think about how we might target our implementation strategies. So we may want to focus more on organizational level strategies to increase use of evidence-based practice. There's a really growing interest in de-implementation, or how we encourage people to divest themselves of existing practices. So we may then target therapists more in that way. And I didn't present all the point estimates, but we did see that the longer an organization had been participating in one of those initiatives, those 5 initiatives, the less CBT the therapist reported using. There's a number of potential explanations for that. I won't go into all of them, but one potential one that comes from the organizational literature is something called implementation fatigue. So it's possible that we're asking a lot of these therapists and organizations, and the more that we layer on top without taking away, the less likely it is for them to do something. So something that was really interesting for me in the process of doing that initial quantitative work was that at every agency I went to, people took me aside in the hallway, or they would say, you know, this survey is great and all, but I want to tell you about what it's like to implement evidence-based practices in my organization. And so in collaboration with my colleague, Becca Stewart, we did something we call the interview project. We were always planning to do qualitative work. We just did it a little bit earlier than planned because we wanted to be responsive to our stakeholders. So this data collection happened kind of in between the survey and the second wave of data collection. And what we really wanted to do was determine barriers and facilitators to implementation with the intention of targeting implementation strategies at those barriers and facilitators. And we used Greg Aaron's exploration, preparation, implementation, and sustainment framework. The cool thing about this study is that we talked to different types of stakeholders. So we talked with the treatment developers involved in the 5 initiatives, all of them. The system leaders, all the system leaders who are associated with the various evidence-based practice initiatives in Philadelphia, and then 80% of the agency administrators who are involved in the implementation process. I'm just going to give you a high-level overview of this. Happy to talk more if people have specific questions. All of the stakeholders described implementation as a delicate dance. They all agreed that coordination, communication, and collaboration were critical. So that if these 3 things did not exist, implementation would not be successful. We heard a whole lot about money, which is probably not of surprise to anyone. But we heard quotes from stakeholders like, we're losing our shirt. We hold our breath and hope when we pay people. They, being the city, really do expect the agencies to sustain how we don't have the funding to support our basic program, let alone anything extra. So really this sense of a dire fiscal climate in community mental health. We also heard a lot about turnover as a serious threat to the sustainability of evidence-based practices. And actually our policymaker stakeholders asked us to explicitly look at this question because they were wondering about the return on investment, because initially the city had been paying for the therapist training and ongoing consultation. So they wanted to know where therapists were going when they left the agencies. So what we found, this was a prospective study where a year after we surveyed the therapists, we went back and found out who was still there and then did a brief interview with the people who had left, was that about a quarter of clinicians and supervisors quit. And I just want to say, a lot of people say, train supervisors, that'll fix this problem. But we actually see supervisors transitioning as well and not staying in agencies. So just like to say that. We looked explicitly if participating in an evidence-based practice initiative increased or decreased turnover. We did not see that effect. You can see in a safe care study that actually it was protective. We didn't see that here. And to answer our policymaker stakeholders, we found that about 50% of the therapists stay in the public sector. So they do leave their agency, but they go to another public agency. And we don't know what the ramifications of that are. If you're trained in TFCBT and you know how to do it well and you go to an agency that doesn't have that infrastructure, what happens? And we found that those that leave do so largely because of personal reasons like elder care or child care, but also reasons about organizational inefficiency and financial strain. So there's a lot of financial concern at the therapist level as well. Something we weren't expecting to see was workforce changes over the course of this study, which is that a lot of the therapists went from being salaried in our system to independent contractors. And actually, this is something that's happening nationally, not just in the city of Philadelphia. So again, our policymaker stakeholders asked us to look at this because they were really interested in this shift. And what we found, looking at the differences between independent contractors and salaried therapists in our sample, was that they had poor attitudes towards evidence-based practice, less knowledge, and in unpublished work, they also endorsed using less evidence-based practice in later waves of data collection. And this is a mixed method study. Administrators was said over and over, we're not going to invest in therapists who are independent contractors because we see them as transient. They're going to leave our organization. And so it's not because they aren't as good as the salaried therapists, it's just that their agencies are likely not investing in their professional development. And this seems like something that we should be attending to. as a major workforce issue. And actually, this has gotten the most press out of this set of work because it was the first study to document that. What I find really gratifying, because I think it's really important that the work that we do have impact, is that our policymakers really took that information to heart. And in a recent request for proposals for new outpatient units, they explicitly stated that new units had to have at least 50% or more salaried therapists. So it's an example of a kind of policy implication of the work. So what does all of this mean? So this work was an exceptional opportunity to really take a magnifying glass and to understand the context within one public mental health system. And it really, I think, unveiled a crumbling infrastructure around the organizations that are working within this system. And so some of you guys have seen this before, and this is, we think of it as Maslow's hierarchy for community mental health. So you see here at the bottom, the agencies are really concerned with keeping the doors open, staying compliant with regulations, keeping their workforce. And they all agree that evidence-based practice is important, but it's kind of like self-actualization. You know, if they can't keep the doors open, evidence-based practice probably isn't going to be helpful. And so I think it really highlighted for me this issue that evidence-based practice is not going to solve these infrastructure problems in community mental health. And in fact, it's a little bit dangerous to layer these very complicated practices on top of organizations that are faltering. All right, guys, so you were maybe wondering about the longitudinal data. I don't know, I've been wondering for 5 years, so I'm excited to finally be sharing this with people. So I've been doing this work largely with Nate Williams, who's at Boise State. He's been analyzing this humongous data set. We used 3-level mixed effect regression models. We had time at level 1, clinicians at level 2, organizations at level 3. And again, this is preliminary, but we did find that CBT use increased on average by 0.26 standard deviations over the 5 years. This is this D is a standardized estimate. I can tell you more about it if you're interested. There was no change in use of psychodynamic techniques. So we were looking at both CBT and psychodynamic techniques. And I think that's interesting for a couple of reasons, but we can talk about that more. The other really cool thing that we found, but again, very preliminary, is implementation leadership as being critical. So you can see here on the x-axis the different time points where we measured our data, and you can see here use of CBT, and it is a truncated range here, so just note that it doesn't start at 0. But basically what you can see is the green agencies are the ones that have the top quartile of implementation leadership. So they had leaders who were supportive, perseverant, knowledgeable about evidence-based practice. And the red agencies had the leaders in the bottom quartile of implementation leadership. And so this is a statistically significant difference in the slopes of those 2 lines. And I know that this looks like this is statistically significant at 2013, but it's not. They're not different at 2013. So we're really excited about this because I think it represents a really fantastic new direction for our work to try to think about implementation leadership. And Greg Ahrens has been doing a lot of really interesting work in the space around his implementation strategy loci. So I think it opens up a whole new direction for us to be thinking about. And I know there's some folks here who are really interested in leadership as well. So quick takeaways from our deep dive into context. Organizational and therapist factors are important. We want to be thinking about general infrastructure and organizational factors and specific implementation considerations like implementation leadership. And this work really now helps us move into wave 4 because now that we understand the context, we can better target our implementation strategies. So now I'm going to talk a little bit about some of the work that we've been dabbling in wave 4. So testing implementation strategies. So one of the things I've been a little bit concerned about lately, and I've been thinking a lot about, is I don't want implementation science to become another underperforming big idea in biomedical research. I think we really need to make sure that implementation research does move the needle. And so I think that we need to be thinking about causal theory, comparative effectiveness of implementation strategies, targets and mechanisms. I know Kara Lewis has been thinking a lot about this work as well. It's really where we need to move if we actually want to have an impact and move the needle here. So I'm going to share another observation with you that came out in the qualitative and quantitative data that I collected over the past 5 years, which is that on the implementation climate subscale asks about whether or not therapists feel recognized or rewarded for using evidence-based practice. Constant floor effect. They all, over all 5 years, they all reported feeling not at all financially rewarded or recognized to use evidence-based practice. In our system, agencies are beginning to receive an enhanced rate for evidence-based practice. And so the agencies are getting extra money, but the therapists are not. So that seems like a potential mismatch and a potential target for intervention. So we just actually published this pilot study, which is really intended to test the feasibility and acceptability of 2 incentive strategies to increase adherence to CBT. The exploratory aim, which was wildly underpowered, was to look at the effect on adherence, and I'll share it with you, but remember, it's underpowered. So just to bring you right back to our framework, so we're still talking about CBT as the intervention here. Now we're thinking about actually manipulating something, which it took 5 years for me to get to this point. So I'm really excited that we finally could do this. And we were interested in looking at social incentives versus financial incentives, and I'll explain that in a moment. So we had 2 organizations that we partnered with to do this pilot study, 11 therapists, and there were 2 conditions. So in the first, I'll just tell you, so therapists were randomized to either get the financial incentive or the social incentive, and we had a meeting with them, and we shared the coding system that we were going to be using, and we said, this is the score you need to get to achieve the incentive. And so they were very clear on what we were looking for. So then they were randomized to either condition. We taped their sessions, all the sessions that we could get consent to tape from the clients. Over 2 weeks, we randomly selected one. And if the therapist hit criterion, if they were in the financial incentive condition, they got $100. And if they were in the social incentive condition, they got an email that we wrote, but that the leader or supervisor sent out to the team saying, hey, Shannon Dorsey did an amazing job this period and did really faithful CBT. That's not the exact wording, but you get my gist. So remember, the first goal of this was feasibility. So we reached out to 2 organizations. 2 organizations said yes. We talked to 13 therapists who were eligible. 11 said yes. And 15 out of the 16 clients agreed to have their sessions taped. So feasibility seems good. We did a lot of qualitative work with everybody who participated, including the therapists and the 4 supervisors, and they all said it was an acceptable approach. There was a lot of talking about ethical tension. This quote best summarizes that. You should deliver your best work, whether you're incentivized or not. There was also a lot of conversation about how being a therapist could be thankless work, and that it was really nice to get this kind of incentive, but there were some concerns about the ethics of it. So this is underpowered. It's not statistically significant, but what you can see is that 5 out of the 6 therapists met criteria in the financial incentive condition, while only about half in the social, 2 out of 4. And so I take this to mean nothing, only that that there may be some effect here, and hopefully we'll have the chance to test it in a more powered fashion. I will say that if you look at the kind of slope over time, they start out high and then they keep dropping over time, and then at post there is a statistically significant effect. We measured their behavior after they were done with the incentive, and it was as low as it could go. So I think there's some sustainability of effect questions that we'd like to answer. So we have submitted for an R01 to do this in an RCT that got a good score that we'll be resubmitting it in 24 agencies. We'll have 3 conditions, and we're adding an implementation as usual condition. We can't really have a control. Our partners are not amenable to that, and we care more about our relationships than having the perfect scientific design. And we've tweaked our conditions based on our pilot findings. Happy to talk about that more. And our implementation outcomes will then be powered to look at adherence and also the acceptability of the strategies and cost effectiveness. So I am now going to try to wrap this up in maybe 7 minutes so that I can give you guys a chance to ask questions, and just share some of my closing thoughts now that I've had a chance to share my program of research within the lens of the broader field. So let's talk a little bit about the future and where I see the future work for myself and the field. I think it is probably not a surprise that I think organizations and leaders are important, and that we need to be attending to them throughout the implementation process. I think that through the work that we've conducted, there have been some key questions that I hope that we can explore in future studies. One is, remember, I talked about the fiscal climate. I think that, that we could do some things around teaching organizations about better business practices. So we often hear from executives at agencies that they were clinicians, they were promoted to be supervisors, and now they're in charge, and that balancing the books isn't a skill set that they were trained in. Kimberly Hoagwood's group is actually doing some great work in New York State around that. Another issue that I think is ripe for consideration is how do we decrease turnover? The rates that I shared are slightly lower in Philadelphia than the national rates, but imagine about a quarter leave a year. That means within 4 years you have an entirely new workforce. So I think there's some really important questions to answer there. I'm sure you've all seen that learning health systems are the rage right now, but I haven't heard as much about learning mental health organizations. And so I think there's some opportunities to borrow from some of those principles and apply them within community mental health clinics. And then, of course, thinking about leadership. And Greg Ahrens has been a real leader in that space, but I think there's probably more room to grow in there as well. But let's not forget clinicians, because who's sitting in the room doing actual therapy with the patient or the client? So I think we have to remember that clinicians are still very important targets of our implementation strategies. And the way that we've been thinking about this most recently is we were just funded through the Alacrity call to marry approaches from behavioral economics or behavioral insights, which is basically psychology, to implementation science. I'm thinking about it like an implementation nudge unit. But let me share some concrete examples about what I mean about that. So the first is thinking about making it easier to use evidence-based practice. And actually, Erin has been doing some really cool work around user-centered design here. But which teapot would you rather serve yourself tea out of? The one with the spout and the handle on the same side, or that electric tea kettle? Anyone? Anyone? Yes, thank you, the electric one. So I think we still have a lot of space to go in terms of making it easier to use evidence-based practice. I'm excited about John Weiss's most recent work around 5 factors of evidence-based practice. So sunk costs. So have you ever written a paper and then had to edit it and then felt a lot of pain about deleting words? Apparently there's a trick. You can have a Word document open and copy and paste in there, and then you don't get upset about it. I use that a lot. But I think this concept applies to therapists, right? So I think we need to think about continuing to make space for therapists to use old approaches and gradually phasing those out in a much more purposeful way. And Christian Helfrich and Brian Weiner just published a paper on coupling implementation and de-implementation that I think will help guide us in this way. So another one is status quo or inertia bias. It's really hard to change the way that we do things. And so pre-service training seems like a really appropriate target. And the way we do things now is kind of on the back end. It's a little bit of a Band-Aid. Can we teach the folks who are going to go on to do direct service how to be a consumer of the evidence, not necessarily be overly attached to one theoretical orientation, but to know how to use evidence? So I'd be happy to chat more in the discussion time about this Alacrity Center. As I mentioned, we're using behavioral economics, which is very, very hot right now. You may have seen that Richard Thaler won the Nobel Prize on his work in behavioral economics. We're partnering with a group at Penn who does this work in health. And we're going to use these insights at multiple levels. So each project targets a different ecological level: patients, therapists, and organizations. So I also think that the field has a ways to go, and I think people are starting to do this, to to use participatory design when we think about designing and developing our implementation strategies. So in the old days, it used to be like, oh, well, we're just going to come up with something and try it. It's an expensive version of trial and error. Now thinking about how to use systematic ways to get stakeholders to help give input on implementation strategy design and understanding the context and designing our implementation strategies to target the context, and that will help us build causal theory. We have a project, it's an R21, where we're doing just that. We're using something called intervention mapping, which is an approach from the public health literature to develop implementation strategies for firearm safety as a universal suicide prevention strategy in pediatric primary care. I also think there's lots of space to apply implementation science to a variety of additional settings. One of the nice things at Penn is maybe on a weekly or monthly basis, someone comes to me from an area that I know nothing about, but is interested in applying implementation science to. So I think there's still lots of space for that. And I'm also interested in moving some of my work into the global space. So have some preliminary work now in Mozambique, but that's a new direction for me. And I think the field is already very well established in that space, especially the work going on here, but can continue to grow. And then, of course, refining measurement. So many of you may know that measurement is a little bit dicey in implementation science, although Kara and her team have been helping us with that immensely. So I have a study where we're trying to identify how to measure what therapists do in session with their clients without doing it the old school way, which is recording and coding, because that's very costly. And so we're testing 3 different ways to measure what therapists do and comparing it to the gold standard.
What are those 3?
The 3 ways are an enhanced self-report measure that we developed using stakeholders to help inform the design, behavioral rehearsal, which is basically a role play between a trained rater and the therapist and what they did in session, and chart simulated recall, which is an interview, a brief interview, and it comes from the emergency medicine literature between a trained rater and the therapist. And we're in the end of the 2nd year of that study, so still will be some time before I can release those results or know those results. So I want to kind of conclude here by saying that I think, and I hope that you guys will agree after listening to me talk for this long, that implementation science can allow us to realize the promise of discoveries and to move the needle. And I think it holds a lot of promise. I hope that you feel like I have made the case that this is relevant to everyone in the room, even if you haven't drunk the Kool-Aid and you don't want to be an implementation scientist, which is totally fine. If you're a treatment developer or you're a clinician or an administrator in an agency, it's really important to think about the principles of implementation science and how it could inform your efforts to increase the use of innovation and improve service delivery. We're a young field, and I think there's a lot of opportunities for junior investigators in a way that isn't true in more advanced fields. These are my kids, and they're wearing future implementation scientist onesies, one purchased by folks here at UW. And I joke about this, but I think that we're building a cadre of implementation scientists, and if you have drunk the Kool-Aid, come join us, because it's a really exciting place to be. I want to remind us that implementation science is fundamentally about improving population health. Sometimes I think we get lost in the academic exercise in our jargon. I think it's important to ground ourselves in that. This is really about improving population health. And then I just want to close by thanking my colleagues and mentors at Temple, at Penn, University of Illinois at Chicago, funding from the NIMH, and then finally my team, without whom I could never do any of this work, and the therapists and the organizations that, that have allowed us into their homes and allowed us to study them. So thank you all. Questions? Okay, you were first.
So do people identify charting and electronic records as a big obstacle? Because I know as a teaching faculty member here, I often feel that there's a trade-off when I could either teach my resident in another 5 minutes, or I could shut up and let them chart for 5 minutes and let them get home to their kid on time.
Sure.
It's an ethical quandary. Like, is that 5-minute talk actually worth it? Or
Sure.
leave the kids alone? And so I think with implementation, you're competing for like people who have huge non-clinical burdens these days.
Yeah, so I think you raise a great point. And in the community mental health agencies I work with, they're mostly not on an electronic medical record, so they do things by hand. But paperwork and administrative burden is a huge reason why it's hard to implement evidence-based practice. But actually in the study that I briefly spoke about in pediatric primary care, that came up over and over in the many qualitative interviews that we have done. One of the cool things though is that in behavioral economics, you can use the EMR to set it up in different ways to change people's behavior and actually get a really big impact with a small tweak, which I was at first like, there's no way, getting people to change their behavior costs so much and it's super cumbersome, but actually there are some things that you can do. So I don't disagree that paperwork and EMRs get in the way of implementation, but I also think we can leverage them in some ways to help change behavior. Yeah.
You were talking about the difference between the salaried versus the contracted. I'm also curious if any of those therapists were unionized, a part of the union.
So in our system, we do not have therapists as part of the union. That has not come up for us. I have colleagues who work in the schools who, of course, have that challenge, but we don't in our system. Yeah.
So when a financial incentive was offered, that the rates went up to 80%, and when not, it was 40%. And then it drifts down to 0. And the thing that pops to mind is you say deleting stuff from a manuscript. And it's like when we do an efficacy study, it's random people. But when you apply it, it's no longer random. In the people that come to see me are not random anymore. If they're seeing me years, then they accept the fact that I'm never going to give them Xanax with Adderall and things like that. So my population of people that I'm treating, they must like me or because they keep. So it's no longer random. So you take something that works for a random population, you change to CBT when you weren't using CBT.
Sure.
And all of a sudden they don't like it. And then they go back to what they were doing before because your patients say, hey, what you were doing was better before. Why are you doing this now? Do you ever consider that implementation is a different population because it's not a random population that are happy with me, that see me over and over?
So I will say in so we are focused on changing therapist behavior. That is really our target. And in the agencies that we work with, it's seldom the case that therapists have been seeing kids for years. A, because therapists don't stay in agencies for years, and B, because the modal number of sessions is 1 in community mental health. And so it's not a situation where most of the time. Now, I will say that we have heard that in qualitative work and in conversations with therapists where they're like, well, it feels inauthentic to be trying one approach with a client and then to like pivot and do something completely different. So it may be in the work that's already ongoing that implementation is even more challenging. So if you get a new case and then you try this, from the beginning with them, it might be less difficult compared to if you were trying to do it with a new person. That being said, if you're tracking progress and it seems like you try something new, I mean, isn't that what you do all along when you're in therapy with a client? If you're tracking how they're doing, you try something new, you don't always necessarily do the same thing all the time. And so I think I kind of answered your question, but maybe not. I don't know.
Well, it's certainly a diverse population, and there's an acute population that comes in, they get better, they leave, and then we got these chronic population that's been seeing us for 20 years, and we're just trying to keep them stable and not have them lose their housing.
Sure.
So there's really a difference in approach in each of them.
Sure.
I've got one more question.
Okay.
If an implementation scientist works for a drug company, what do you call them? Because it seems to me they've been working on this a long time. And from a step 1 question, it'd be like, which gets more bang for the buck? Buying a steak for the nurses and social workers or buying a steak for the doctor? Right? Has anybody ever looked at that?
About buying steaks, I'm not sure. I don't
I'm
know
sure
that
they're looking at
literature
that.
very well. I
Okay.
will say I have been approached by pharmaceutical companies to consult with them about implementation science. So even the pharmaceutical companies, I think, are still figuring out
Because they track,
how to change
I've been
provider
told that
behavior.
They track what we write. Like track our prescriptions. If they buy as a state and we don't write more of their stuff, they're not buying as any more state.
Well, and
Those of us that don't work at Harvard, but they used to buy as
right,
states
and now they
and
can't,
they would
right?
keep track and very concrete, objective endpoint, which is how often the medicine is prescribed that they want versus advertising to patients versus advertising to us versus buying us stuff versus buying staff stuff. And they're probably not publishing that stuff, but does anybody consider what they find?
I do not know that literature, but I'm waiting for your clever answer to what you call an implementation scientist that works for a pharmaceutical company. So I'll confer with you on that later. I think there were maybe a couple more questions. Sarah?
Yeah, I was just wondering, I know that study was underpowered and everything, but do you have any theories for that, where you're seeing fidelity and incentive type, about how the leadership style, that agency might be interacting with that relationship?
Yeah.
And presumably, if you have strong leadership, they're already engaging in public accolades, so you wouldn't see a.
That's a really insightful comment, and yes. So first of all, we didn't quite get the social incentive right in the pilot. So we heard from people that it felt inauthentic. Like one of the directors always did like emojis, and she was super effusive, and they already had some of this going on. And so they were kind of like, we don't care about this email. Like it doesn't really impact us in the same way. And so actually we've changed the condition now to be a leaderboard, and we're trying to build in more of the kind of social norms literature into the way that we think about that condition. We are looking at organizational culture and climate, and you raise a good point. We should probably look at leadership also now, especially given the finding I just presented as a moderator in the larger powered R01, because we think that in the organizations that are already strong, this kind of intervention probably has less of an effect. But that's an empirical question, but it's a great one. Yeah.
Yeah, just two thoughts. One, to follow up on the thing about the drugs. If you look at mental health care and where the money goes, the biggest change in the last 30 years is all around. We've manipulated lots of people into taking drugs, not taking drugs, mostly taking drugs. Those guys know a lot. I don't know what you call it. I mean, it's some form of marketing, right?
I'll buy you a drink if you come up with a good name.
And I think it's worth looking at what they know, from marketing, because it's pretty sophisticated. The second point is, if you want to go all the way to population health, at some point you got to go beyond measuring just are they doing CBT, because you got to say, is the kid getting better? So I'm not convinced that if the kid's getting sulfurated by their therapist in your study, that they did more CBT, the kid's more likely to have gotten better. So if you want to go to make the claim all the way to population health, at some point you got to see, is the kid actually getting better?
I agree, and you know, the reviewers of our R01 said exactly that. So we will be measuring kid outcomes. Population health. Yes, Aaron.
I'm totally on board with sort of the future directions for implementation science. The one that sort of sticks with me is the pre-service training, but I also feel like that's something people have been talking about since wave one.
Yeah.
Right, and the importance of pre-service training, and obviously we're not talking about pre-service training for most, or at least in most cases, for psychologists and psychiatrists, given the sort of, at least with regard to direct service provision, the negligible impact and the tiny sort of segment of the service delivery population we're talking about. But what do you think are the continued barriers to implementation science having a large impact on pre-service training?
So I just want to nod to my postdoc, Emily Becker-Hames, who's really interested in this and has taught me a lot about it. So I'll do my best, but if you want more in depth, we should talk to Emily. So it seems to me like there's some guild issues here, because there's different types of folks who are providers. So there's MSWs, there's MFTs, there's folks with masters. There's not like one kind of group that oversees all of them. And even in psychology, I mean, have you been following the controversy over the PTSD guidelines that just came out? The listserv is like, the APA listserv is blowing up about how dare the APA release these guidelines. So I don't think we're kind of as psychologists immune to this issue. So Emily proposed to do this grant where she would work with 5 agencies, and not agencies, master's programs, and teach the trainees how to use CQI, so continuous quality improvement. And how is someone like me going to go into a program with established professors and say what you're doing is not right? And you need, you need internal change. I think you need people from within who want to change. And so I'm not sure how we're going to do this, other than to get folks who are either in the programs now or the new hires who might be more amenable to these types of approaches. So I think it's a important future direction, and I think it's going to require some more thinking.
We should probably wrap up. Fabulous presentation.
Thanks,
Thank you,
guys.